All right, today we're going to be going over procedures of the lower extremity. So pelvic girdle all the way down to the toes. So here we have a coronal T1 weighted image. Remember, with your MSK imaging, it's tough to sometimes tell what the weighting is. And why is that? Huh?
Not a lot of fluid.
Not a lot of fluid. I mean, there might be a little synovial fluid, but here, the acetabulum, that joint space is so narrow, all you see really is that cortical bone between the femoral head and the acetabulum. You can't really even see the fluid. So what is the next thing you should go off of?
Water.
Well, if you can't see the fluid, fat. No, because fat's right on both, unless fat's added.
Muscle.
Muscle. Remember, which one has darker muscle, T1 or T2? T2. So this muscle, in the realm of being dark muscle, is pretty light. So this is a coronal T1. So we can back that up and validate it because our subcutaneous tissue is really bright too. So, and we have bright marrow within the fat of the bone. Is this a male or a female? Female? Why? It could be the slice, guys. I know what you're thinking. It could be the slice where we're at. It's actually a male.
No way.
What's the organ that women don't have?
Prostate.
So, come on, y'all. What is this thing right here?
Prostate.
Prostate looks like a wound up ball of rubber bands. Alright? So, you can go through the anatomy here. So, make sure you know all the anatomy. You know, most of my tests, I pull the images from these slides. The weighting here is pretty easy, right? We got a bunch of fluid. So that's our bladder. So, and then see here, we have just a tiny rim of synovial fluid. So if we didn't have this, it would still be a little tough to tell. But look at how the muscle is a little bit darker here than here. Oh, not so much, but a little bit. Side-by-side comparison would be better. It would be lighter. Here, what do we got? Sagittal. Once again, it's tough to tell. T2, we got a little fluid, it looks like maybe right here. Muscles a little bit darker. Your sagittal, they're really looking at these meniscus here and your ligaments, things like that. If you had to guess, which meniscus is this? Which horn? Like you have a lateral, medial, anterior, and posterior horn. So give me the most specific horn of this meniscus right here.
Yeah.
But what? Posterior, medial, or lateral?
Medial. Lateral.
It's lateral because of, you can see one structure. What is that structure? Look underneath it. What is this bone right here?
Oh, the fibula.
Fibula sits lateral, right? So this is the lateral slice going through the knee of the sagittal. So this is the posterior lateral meniscus horn. Okay. Here's another pretty bad image quality, but this is really how you would angle your slices. This is a good visualization of your ACL and your PCL. Your ACL is visualized by the obliquity of it. So almost at 45 degrees, that's how you can tell it's ACL. ACL goes from posterior of the femur to the anterior of the tib. And then your PCL almost goes posterior, starts going posterior, and then it takes a sharp right angle down. So that's how you're able to tell the two tendons apart. Here you can see the meniscus. You can see the tendons starting to come through. What's that fossa called?
Intercondylar.
Intercondylar. We have the spikes. What are those called?
Meniscus.
Tibial spine.
Tendons, spines. And then what are these tendons over here on the side? MCL, LCL. Cruciating, medial cruciating. Okay. Fat set. We know this is a fat set compared to a stir because we're starting to lose the homogeneity of the fat set. Fluid's bright, so it's a T2 fat set, axial. And since we just learned that, that could be because of that shading dielectric artifact where the top of the knee is touching the coil compared to the bottom of the knee. More uniform fat set usually means it's a what? Not fat set, but stir. Short cow inversion recovery. So very uniform fat set along the entire ankle and foot. So we know we usually image both of these at separate times. For an ankle, you kind of only need about right here. For the forefoot, you need like that. Obviously, I've turned this to match it up with the foot. But you should not be imaging the ankle and foot together. Your field of view is too big. Your spatial resolution would be poor. Here is a coronal ankle. And in MRI, you don't have to go up so high with your field of view. They're not as concerned about this area up here as, remember, it's a joint space. Just like with any MRI, your field of views really need to be small for MSK. You don't need all of the extra tib and fib and all that up there. They're always really just looking at the joint space. All right, so here's some indications. I broke it down by body part. So you can see here some of the ones that are unusual. Labral tears. Where else do you have a labrum? Shoulder. Avascular necrosis. So what could cause that avascular necrosis in the hip? Old lady falls and does what? Breaks her hip right at the femoral neck. The head of the femur starts to lose blood flow because there's that complete break. Avascular necrosis. We lose blood flow to the head of the femur. Ligament tears, arthritis. Femur, it can be hamstring injuries. So hamstring on the front of the back of the leg. Back. Excuse me. The back of the leg. What's on the front of the leg?
Quads.
Quads. Nick, you better know that. Leg day. Unless you're skipping leg day, right?
Oh, no. No skipping.
Knee. Ligament tear is a big one. Meniscus tear. ACLs, PCL, MCL, LCL, meniscus tears. So a lot of sports injuries, right? So you're at your Hawks facility. Did you see a lot of knees, Rachel? A ton of knees, yeah. All your athletes are constantly doing those quick movements, right? And then they get their leg caught, or somebody comes and throws 300 pounds in your knee. That'll tear a ligament pretty quick. Tib fib. Neoplasms and infections a lot of the time with the tib fib. Shin splints. Shin splint, a lot of our runners get shin splints from constant wear and tear. Things like that. Ankle, the big one, Achilles, strongest tendon in our body, right? But ruptures a lot of the times in sports injuries when you completely stop and you make a quick burst of movement and your foot just kind of stays there. Plantar fasciitis. I remember Michael Panis was constantly suffering from this. Plantar fasciitis. You have fascia on the bottom of your foot. So if you guys ever had, if you have like flat feet, anybody have flat feet and have that kind of issue?
I x-rayed.
There's a lot of pain kind of near the heel. So a good remedy for plantar fasciitis, not only like obviously like massaging it, using that ball to roll on, like a tennis ball or any type of like massage ball, putting extra arches in your shoes, increase the arch. That helps like stretch out that fascia so that you don't get that inflammation. What were you about to say, Nick?
I x-rayed a woman yesterday at the clinic across the street with plantar fasciitis, and she had the flattest feet I have ever seen.
Yeah.
Like it was like literally.
Yeah. I got flat feet, but not
But in all
flat.
the all the feet that I've x-rayed so far, I was like,
Yeah.
oh my god.
Yeah. So very common with flat feet. And you know, Mike was telling me when to fix it, what they do sometimes to like regenerate like healthy growth is they just cut slits. Like just they go in with a needle, or not needle, I can't even, what's the knife in surgery called? Scalpel. And they just make incisions in the fascia, and then it regrows more healthy compared to the scar tissue that had formed. So they just basically cut the scar tissue out, and then they create these little slits. I was like, oh man, that's
So why is
sounds
healing
very
like
barbaric.
that? Can you go about your like normal functions whilst healing from the?
Yeah, but he was just in a boot, so it's just like he doesn't put as much weight pressure on. Yeah, but no, I mean, yeah, he was back up on his feet. Sinus tarsi. Where's the sinus tarsi at?
The calcaneus and the tarsal. Yeah.
Talus.
Talus.
Tarsal.
Tarsal.
Yeah, and you got a lot of ligaments and things going through the sinus tarsi. And then foot, Morton's neuroma, we'll talk about that. It almost feels like a little pebble. It's just like a little benign tumor at the bottom of your foot. Can be caused by, I thought it was funny, by women wearing high heels. Like, I was like, man, women already do enough pain for beauty type thing. I was like, Morton's neuroma. Oh. And then other things we already talked about. Okay. Patient prep, you know, anytime, just get them changed, but we can do a lot of these feet first, right? We're going lower extremity, so we don't really have to worry as much about our claustrophobic patients, because we can go feet first. So we're pelvis down, we have the luxury of offering the patient feet first. And then remember our vitamin E, or they have the expensive ones in your department. Just make sure you're marking where the pain is. If it's a direct location, mark it right on it. If it's a range, if they're looking like, you know, if you see an incision or something like that for a tumor, maybe put one at the top, one at the bottom. So if it's a range, put 2 of those markers. If it's a direct, if the pain's right here, put it right on the spot. Anybody use those little markers? Yeah. Hip. Main thing with the hip, you can provide them a cushion under the knee. You can't provide a cushion because you want to make sure, just like with a hip x-ray, you want to take those toes together because you want to make sure that you're not foreshortening that femoral neck. Even though you can angle your slices with it, you still want to see on a good coronal, you want to see that greater trochanter out on the lateral side, okay? And very minimal of that lesser trochanter. So we still, no cushion, and then you're taping the toes together. But remember, put a foam pad in between those toes because of our dielectric artifact. Positioning-wise, you put the coil just like you would be imaging for a pelvis. You put the coil, you feel for the crest, top of the coil at the top of the crest. Feel for those greater trochanters, make sure the coil is below those greater trochanters. You can see here we're doing mostly fat-satted imaging. Some in and out if we want better uniform fat set. And we're getting all 3 planes, coronal, axial, sagittal. Coverage for our axials, we want to get basically from the ASIS all the way down below the lesser trochanter. Make sure you're basically parallel and perpendicular to all those structures. you know you want to be able to see the right hip and the left hip on the same slices. So that's why it's so important that not only are we getting adequate coverage, but we're angling our slices. Because anytime you're imaging two things at once, the radiologist is better going to visualize maybe a possible pathology if you have the slices for the hip on the same slice. So that it's abnormal on this side, normal on this side, I can better see that because I'm constantly getting the same depth of that anatomy. Sagittal, you can go just straight across, or you can angle with the femoral neck. Each place is different. What have you guys seen with the sagittals on the hips? At 59, at Resurgence, at Hawks, have you guys done many hips?
I think the angle was wrong.
Femoral neck, okay. Or you could, once again, you could just straighten this out, go a little bit more clockwise, and just go straight with the anatomy. Coronal, coverage-wise, pubic symphysis to the ischial tuberosity. Why is the ischial tuberosity important? Gets the entire ischium, basically. So you get the entire acetabulum. The ischial tuberosity is the thing we sit on, so we pretty much have gotten all the bone coverage that we can get. We have an arthrogram of the hip, just like with the shoulder. That is very common. We also do it at knees, wrists, less common, but I talked about this last time. This is the mixture. Make sure you do a test run with a patient. Make sure that they're not claustrophobic before they go in and do the actual injection, and then they come back for your part, and then they freak out. So remember, draw up the contrast. Have them fill out the screening form to see if there's any contraindicated devices, and do a test run if they mark on that form they are claustrophobic. Femur, long bone, we're using the largest coil or two coils linked together. Mammoth, joint to joint. EP59, if they know it's a repeat patient or if it's like a cancer patient where it's in a specific area, you don't need to get joint to joint, but they like to see at least one joint. It's a long bone, just go perpendicular to the bone basically. Your axial slices might take a while because obviously you need to cover from all the way at the hip down to the knee, so that might be your longest sequence. Sometimes they get a bilateral with the femur, because once again, comparison reasons. Sometimes they'll just get one bilateral and then do the rest unilateral. Knee, here's all our different coils. We have the stronger channel or higher channel coils, give us more signal, and then lesser channel coils over here. If a patient is too big to even fit into your knee coil, what do you think you would use? A what?
Flex coil.
Flex coil. Flex coil. Just wrap it around, tape it up. Centering your isocenter beam at the apex of the patella. So that's kind of tough sometimes. Like I've had to do multiple times where I've had to reposition you. You're like, you tell them to, all right, they're sitting up there, they're watching their knee get put in the coil. And then when they lay down, it like shifts their entire body up a little bit. So sometimes you have to go in there and reposition for that knee. Have you guys, anybody had problems where you don't get enough signal from the actual knee part?
Yeah.
And then you're getting too much like tib or too much femur, and you're like, all right, well, I gotta go back in there and reposition my patient in the coil. Remember, sponges are your best friend. Just pack it in there. Obviously, a pillow underneath so you don't have any bend at the knee. Here's how Emory likes to angle their slices here. So you got your coronals going with the condyles here. So you basically have the medial and the lateral epicondyles. I think this is the medial, this is the lateral. It's hard to tell until you get to see the fibula. So you use coronal slices going with that. Sagittal, they kind of go from the medial condyle, the intercondylar fossa, they kind of angle it with that. Some places do the lateral condyle and they'll angle it with the lateral border of it. So I'll show you both. And then axial is obviously head to foot. Axials, a lot of people say just to get, if you have the patella, make sure to get 2 or 3 slices above the top of the patella, which is called the what? What's the top of the patella called?
The base.
Base. The base. So make sure you get a couple slices above the base of the patella, and then you need to get past where you have the joint between the tib and the fib. So you need to have some of the fibula on there. You can put sat bands above and below. What artery we were trying to prevent flow from? Popliteal, posterior. So you can put your phase direction right to left because we only have one coil on the patient, so we're not worried about the other knee wrapping into the patient, into this knee. So you can put it right to left, and you don't need oversampling, so that we're not concerned about the blood flow coming down. And if you really want to make sure that we don't get that artifact, put a sat band above and below the field of view. So here's the sagittal, the hospital I worked at in DC, this is how they angled. They angled with the lateral condyle. So basically this matched up this. So that was with this. And that was to get a really good visualization of the ACL and the PCL. So, and you can see how it kind of matches up here too. So that's, Emory does it, but I'd say Emory, we take off a little bit of our angle. So we'll go a little counterclockwise, so it's not such a drastic angle, okay? And then make sure you get coverage from MCL to LCL. And like a slice past those ligaments. Because remember, we're not concerned about the subcutaneous tissue. You'll see that tibia pop out over here too. You need to make sure you include that. And then coronals angling with the back of the condyles, the posterior part of the condyles. You can see how that matches up. All right, and then if you specifically want to see that ACL, sometimes they'll base it off your sagittal, and they'll find that ACL, and then they'll do like 5 or 10 slices right through that ACL, and you angle it with that oblique ACL. Remember, it's coming from the posterior femur, attaching anterior to the tibia, and then you'll get these slices where you can see basically the length of the ACL. So it's really good if you're trying to really rule out a ACL tear. And then here's just if they want to get thin slices of the sagittal. So that ACL kind of comes from this direction down. Lower leg, flex coil, joint to joint, mid isocenter, mid tib fib. Might not be able to get both joints. Find out where the region of interest is and get the joint closest. Because we start to get, what's that artifact? We start to get towards the edges sometimes.
Shading.
Shading. Zebra. Sometimes we get that warping around the edges. We start to lose the homogeneity with the larger field of views. So you can see here our phase direction is A to P because we don't want the other leg to wrap in. Because remember, we have the coil laying on both legs. So now, unlike the knee where we isolated one knee with just one coil, we have the flex coil laying on both legs. So we don't want our phase direction to be going right to left because this will wrap into this one. Coronal, they want to get a bilat. You can see a little bit of pathology here, shin splints on the left leg, and you were able to actually see it a little bit here on axial too. You guys see that? The increased signal on your stirs. This patient has some kind of pathology, most likely shin splints because it's anterior of the tibia. Ankle, You can use your knee coil. Some of the knee coils have that little chimney opening for the foot to go into. Not great for forefoot because the toes stick out. Obviously, you need to get all the signal on the toes. The chimney coils are ideal. Anybody handled a chimney coil yet? MOTs, Hawks, where else are they? ET59, I'm sure has one. What Melody, did you see a chimney coil? If not, you can use knee coils because most knee coils have those openings up top where you can put the foot. Okay, so just make sure that this line of the coil matches up with the malleoli. Anytime you're doing an ankle, you want to make sure that it's flexed, dorsiflexed 90 degrees too. So that's really important, especially at like Hawks, places like that. They're really concerned with making sure it's really dorsiflexed. So here you can see the doors. And you have those sponges too. So this is a knee coil, but they have sponges specific for ankle. So it's open on one end and then it allows that dorsiflexion of the foot. So obviously we wouldn't get signal from the toes because the toes are out of the coil, but we're going to get signal from the ankle. So here are ankle and foot protocol. So ankle is sometimes called hind foot, and then your toes, forefoot. So things, ligament tears, osteomyelitis. So you got diabetic ulcers of the feet a lot of the times for inpatients because the back of their heel is laying on that bed for hours and create the cutaneous ulcers, things like that. So here's your ankle. Remember, we don't need as much tib-fib, but we really are concerned with the joint. And you need to get all this soft tissue down here, so they might need to move this down a little bit. Because you are concerned with this soft tissue. Remember that plantar fascia is down here, so you need to visualize that too. Sagittal angling perpendicular with the malleoli. So here are our malleoli. Try and find the apex of the malleoli and angle it, so they could probably tweak this a little bit. But sometimes it all depends on how the toes are oriented too, because you really want to see as much anatomy as possible sometimes. All right. Come on. Foot. The feet can be an issue sometimes, especially if you don't have a chimney coil. You could use a brain head coil. Or sometimes you might have to, has anybody seen this, where they bend the knee and then they put the foot flat in the knee coil or the head coil. So you're bending the patient's knee up, and you have to be careful not to bend it up too much, or else they'll hit the top of the bore of the magnet as you go in. You don't want to scrape the top. And you just are basically laying the foot flat to get good signal from it. Or you could do something like this with the sponge. So your axials, you need to really get tarsal bones all the way up to the very tip of the toe, so they need to add some slices here to get the very tip of the big toe, all the way back to the tarsal bones. Your saddles, right to left. Remember, we're just concerned with the forefoot. So from skin to skin, they call it. And then your coronals. So your coronals should look like this. Some places the coronals and axials are switched. Anybody that's done a forefoot, is this the Emery axial and Emery coronal? Does this ring a bell?
No.
Haven't done a forefoot. And then remember, with anytime we're dealing with a lot of metal in the hips, metal replacements, knee metal replacements. So if we do have metal in the patient, we need to switch from our fat set to our stir. Our stir has that 180-degree refocusing pulse, so it corrects for those magnetic susceptibility artifact, chemical shift. So here it says no frequency select fat set. That's that spectral fat set. Spectral fat set, where we find the peak of fat and we're putting that cursor right on the fat. We can also increase our receiver bandwidth. Remember, it compensates for chemical shift, but it also compensates for magnetic susceptibility. Make your matrices better resolution, reduces that metal artifact. Increase your next. And then they want your matrix to be 224 by 192 per stirs. Because you really start to, you lose signal when you're going to stir. So changing your resolution sometimes helps. All right, and we'll go over the pathologies next time, just a quick little blurb on the pathologies. Or if you just want to watch the video on the pathologies, that's totally fine. So next time we'll go over, we'll start on vascular. But remember, this weekend, we're just testing on artifacts. So really study up on your chart, know what these images look like, be able to match, things like that, and know the axis that it occurs on, phase, frequency, both, or slice select. Anybody got any questions?